if you want us to ask any questions, and we will keep an eye on that. So guys, let us know where you're from. We'll give you a quick shout out. So whereabouts in the country are you joining us from? Which exam are you preparing for? And we'll be able to then kind of get a flavour of where you're all joining us from. So I can see, just while Dr. Mo gets the stream ready on YouTube, we've got Jules, who's joining us from London. Welcome, Jules. Which exam are you preparing for? Oana is in Surrey, preparing for the MSRA exam, so welcome. So looking to come into GP training. We've got Sarah Khan, who's in Manchester, who's sitting the AKT exam in April. Welcome, Sarah. Jules has just finished the MSRA and is awaiting offers. Exciting times. Hopefully you get your first choice and you get to enjoy GP training and what it has to offer. And of course, you know, I'm sure you'll keep an eye. We can support you through your GP training journey. Chris is from London and doing the AKT in October, so you've got quite a bit of time before, so it's good, preparing nice and early. Innocent, welcome Innocent. So Innocent, we know Innocent very well. Welcome Innocent all the way from Nigeria. It will be probably an hour ahead in Nigeria, so I hope you're keeping well, Innocent. Good to see you there. Not doing any exams yet. Faryal Zafar is joining us from Stevenage, starting GP training in August. So again, very exciting when you start GP training in the beginning, because it's a new kind of, you know, you've got a speciality, you can now start career planning and looking forward. So it's always, I always remember it with great excitement when I was about to start GP training. So hopefully you will enjoy it, Faryal. Delapo is from Reading, preparing for the AKT exam in April. We've got Roy Abraham, who's preparing for the AKT exam in July and joining us from Australia. Roy, what is the time in Australia? So what I love about these webinars, because we get people joining us from pretty much all over the world preparing for the RCGP exam. So I'm assuming it's going to be obviously a completely different time zone. It's 7 o'clock in the evening in the UK here. We've got Shaney, so forgive me, Shaney, if I don't pronounce this correctly. So Shaney Matthew is joining us from Blackpool, working towards the CREST certificate and planning on doing the GP exam later in this year. Fantastic. Farshid from Birmingham, waiting for the CSA result. I think Farshid is someone who may have done one-to-one coaching with you, Dr. Mo, but welcome, Farshid. So fingers crossed, hopefully your CSA result goes well. We've got Roy, 6 a.m, fantastic. So Roy Abraham joining us from Australia, preparing for the AKT in July, and it's 6 a.m. That's what you call commitment, guys, waking up so early to join us. We've got Yvonne Lewis from Liverpool, booked and cancelled the AKT in April and hoping there will be an AKT in July. Yep, fingers crossed, Yvonne. So hopefully you'll get an extra sitting and a chance to kind of sit the AKT exam, or maybe it'll be later in the year. Lots more people now joining us, so welcome, guys. Last maybe 30 seconds, if anyone else wants to do a quick shout out. I can see quite a few of you have now logged in, and I can see that we are also now live on the iMedics YouTube channel. So last 30 seconds, guys, before we get cracking. If anyone wants to do a quick where you're from, which exam you're sitting, and which kind of VTS you're in. Otherwise, I think we're pretty much good to go. Here we go. We've got one more person who wants to say. So Waleed from Lagos, Nigeria. Fantastic. So far and wide joining us, not preparing for any exams yet. Waleed, well, welcome. It's good to refresh your knowledge and start planning early. So Dr. Mo, I'm going to hand over to you then, and you make a start on your first topic.
Okay, everybody, welcome to the iMedics free webinar teaching, which is for the AKT, RCA, and the MSRA exam. This is a pregnancy-themed free webinar, so we're going to be focusing on antenatal care and also nausea and vomiting. So as you know, if you've joined us before, we're trying to focus on the key topic areas which are most likely to come up in the written exams, but also knowledge that you'll need for the practical exams as well, like the RCA. So I'll start off with antenatal care first. We'll cover the latest NICE guidelines, but there will be a focus specifically on lifestyle type antenatal care, which comes up repeatedly in the AKT and the MSRA exams, and it can also be commonly assessed in an RCA video type station. There'll be an opportunity to ask questions. We'll take a very, very short break just to highlight a couple of products. So tomorrow we've got an RCA Advanced Communication Skills course, which some of you may be interested in. We've got an AKT mock coming up. And of course, we have some MSRA products as well on our website if you're preparing for that exam. After that, Dr. Sandel will be talking about nausea and vomiting, a relatively common topic which does crop up both in clinical care but also in exams, and that's going to be pregnancy-related symptoms. And again, there'll be an opportunity to ask questions. And then finally, we'll just talk a little bit about our social media channels, which you may want to follow. We've also got a new forum chat section on our website. So without further ado, we'll get started. For those of you who are just joining us, don't worry, you haven't missed much. We are just getting started. And as usual, the theme and the focus will be to try and cover the high yield information, which is going to be relevant for the exams that you guys are sitting. And today's teaching topic has a pregnancy theme. If you signed up on Zoom, you would have noticed that. So let's get started. Let's do a very, very brief recap first. So my topic is going to be antenatal care. And I've got a typo there already for those of you spotted it. And we're going to be focusing on lifestyle management with regards to antenatal care, because that specific area of the NICE guidelines is heavily tested in a lot of exams. So first of all, who does this apply to in terms of the actual NICE guidelines? So the actual NICE guidelines apply to uncomplicated pregnancies. So for example, if a woman who's got diabetes during pregnancy, or she's got a background, let's say, of HIV, this topic would not apply to that scenario. So you're looking at specifically uncomplicated pregnancies. And in uncomplicated pregnancies, those are usually managed by midwives in the community. Throughout the journey, in terms of when the woman first obviously sees the midwife until the very end when she gives birth. So what we're going to cover is a couple of key topic areas, which include diet, alcohol, smoking, toxoplasmosis, travel, sexual intercourse, exercise, work, maternity benefits, vaccinations and scans, and what knowledge you need to know around these topic areas, which will be very, very relevant for your preparation. So let's get started, because there's quite a lot to get through, as you can see from these topic areas, and you may want to make notes as you go along. We are recording this, so we are live streaming to YouTube, so there'll be a recorded copy of this if you want to come back to it. But if you want to make notes, that's probably going to be more than beneficial for your own reference. So first of all, in terms of diet in an uncomplicated pregnancy, with regards to antenatal care, there are certain foods that should be avoided during pregnancy. And these are foods which may contain, on this slide, Listeria or Salmonella. So some of you would already know this, some of you, this may be new information. So certain foods can or may contain Listeria, and if a woman consumes those foods during pregnancy, it can lead to a Listeria infection, which can increase the risk of miscarriage, stillbirth, or severe illness in the newborn baby. So which kind of foods can increase the risk of developing or having a Listeria infection? So these are usually the soft mold ripened cheeses. So these are cheeses, when you go to the supermarket, have a blue or greeny tinge on them. Camembert, Brie, blue vein cheese. But the other ones to remember are unpasteurized milk or cheese, and pate, which includes vegetable pate as well. For those of you who are not familiar with these food groups, you may want to Google it so you can see what they look like. If you're not familiar with pate, again, if you Google it, you can see what the different products that are available in the supermarkets are for pate type products. The other food to be aware of is foods that might have or increase the risk of salmonella type infections, and these are usually uncooked, undercooked, ready prepared meals. It can include meats as well, and also raw shellfish such as oysters. And the risk with salmonella infection is that whilst it's unlikely to be harmful for the baby, it can actually be very, very harmful to the mother. So it can cause serious illness in the pregnant woman. And so the key foods to remember are obviously uncooked or undercooked ready prepared meals, uncooked or cured meats, which can include salami, and raw shellfish such as oysters. So this is actually, these two topic areas are relatively commonly tested in the AKT and an MSRA type setting. More so the AKT, less so the MSRA, but certainly information that you need to know. Now, there are other foods that pregnant women should avoid, and those include liver and liver products. And the reason for that is liver products and liver tend to contain relatively high levels of vitamin A. And if you ingest too much vitamin A during pregnancy, it can increase the risk of birth defects. Then there's certain fishes which can contain very or relatively high levels of mercury. The specific chemical is methyl mercury, and those foods can include shark, swordfish and marlin. So those food groups will perhaps be a little bit more common in Oriental diets, But again, something that you want to counsel the mother on, for example, in an RCA type setting. And then increased exposure to high levels of mercury in the womb can affect the fetus's nervous system and potentially increase the risk of behavioral or learning problems later on in life. In terms of other food groups, the NICE guidelines do also recommend restricting the following 2 food groups, not stopping them or cutting them out, but restricting them, and that's tuna and caffeine. So in terms of tuna, you should the pregnant woman should not have more than 4 medium-sized cans in a week, or 2 fresh tuna steaks per week. And the reason for that is tuna can actually contain high levels of mercury. And then in addition, caffeine should also be restricted to less than 200 milligrams per day. And don't forget, caffeine is found in various different products. So for example, chocolate, tea, coffee, Red Bull, energy drinks. And those are all things that a pregnant woman should be made aware of. And high levels of caffeine have actually been shown to be associated with low birth weight in the baby. In terms of diet and vitamin supplements that the woman should be taking, you should all know this information. So folic acid and vitamin D. So folic acid, 400 micrograms, should be pretty much ingrained in your brains. It's supposed to be taken pre-pregnancy, so before conception, and all the way through till the 12th week of pregnancy. And it reduces the incidence of neural tube defects. And you can buy this in combination type products like Pregnacare, for example, or as a standalone supplement from most pharmacies and places like Holland and Barrett's, for example, or any other reputable supplement store. Vitamin D is also recommended throughout pregnancy and also breastfeeding, and the specific dose is 10 micrograms per day. And then the other thing to make women aware of is that vitamin A supplementation should be avoided. Again, for the reasons we've mentioned in the previous slide, you want to avoid doses of above 700 micrograms per day because it can be teratogenic. Now, some women may ask you, for example, this could be an RCA type consultation that you're recording, or possibly even a day-to-day clinical setting in a hospital, where a woman may ask, do I need to take iron supplementation because I'm pregnant? And the short answer to that is no, it shouldn't be offered unless it's clinically indicated, and that would normally be something like anemia, iron deficiency anemia, and that will be usually picked up in the screening blood tests that are done by the midwife. In terms of exercise, so let's move on to exercise and pre-pregnant and antenatal counselling. So moderate exercise is okay. So certainly it should be encouraged. It's of course healthy. So for example, 30 minutes of exercise 5 times a week would be considered government guidelines at a moderate intensity. But the NICE guidelines are very clear that the woman should avoid any sports that may cause either abdominal trauma, possibility of falls, or excessive joint stress. So a good example will be something like rugby. And then the other sporting activity which is considered or not recommended to be done during pregnancy is scuba diving. And the reason for that is there's an increased risk of birth defects and fetal decompression disease. So for those of you who haven't heard about fetal decompression disease, basically what happens when you go scuba diving, obviously you're underwater, that results in a change in the barometric pressure when you go underwater, because you can think of water essentially pressing down on an individual the deeper you go. That change in the pressure as you do scuba diving can cause gases to be released within the body, and those gases can obviously cause harm to both the individual but also the fetus. So there's changes in pressure in the gases that get released, and those can be harmful. They can cause, in very severe cases, a coma or even death. In terms of alcohol, smoking, and drugs, so I think it's relatively clear here from the NICE guidelines, and something you should have, of course, covered during your med school training, which is pregnant women should try and abstain from alcohol. No level of alcohol consumption is proven to be safe. So 1 unit, 2 units, 3 units. The guideline does 0 units. And in terms of smoking, now this is a relatively tricky area, because it's a lot of women who perhaps might be smoking may not mention it if you're screening for whether or not they're smoking. And of course, Midwives tend to do carbon monoxide testing, which is a better way of trying to work out if a woman's smoking during pregnancy. But essentially, if a woman is smoking during pregnancy, you want to offer smoking cessation services, because it can increase the risk of miscarriage, preterm birth, low birth weight, and stillbirth as well. And then, of course, very, very clear guidance from NICE to refrain from recreational drugs. In terms of sexual intercourse, some women obviously can feel a little bit nervous about sexual intercourse during pregnancy because they feel like it may be detrimental to the baby, but actually it's safe throughout pregnancy, no matter what, whether your first trimester, second trimester, or third trimester, it's safe throughout pregnancy. Moving on to toxoplasmosis. So this is essentially an infectious diseases curriculum area, but it overlaps into antenatal counseling because there's a risk a woman can actually pick up a toxoplasmosis type infection. So what is toxoplasmosis? So it's a parasite. The parasite is known as Toxoplasma gondii, and it can be acquired in a range of different ways. So if you underprepare or undercook food, specifically meat, if you don't wash fruits and vegetables, which might be contaminated by cat feces, if you accidentally ingest cat feces after you're handling cat litter, or if you're coming into contact with lambs or sheep, there's an increased risk of contracting the parasite Toxoplasma gondii, which can then result in toxoplasmosis type infection. And because if that does occur during pregnancy, toxoplasmosis can actually result in spontaneous abortion, stillbirth, and fetal abnormalities as well. So the advice here is relatively straightforward. Make sure you're cooking meat properly. Make sure you're washing fruits and vegetables properly. If you're handling cat litter, wash your hands after you do that, and try to avoid contact with lambs and sheep. So that would probably apply more to a patient or a female in a rural type setting or in a farm type setting. So if it's her livelihood or occupation, or she works in an environment where she has to handle lambs or sheep, so perhaps a veterinary surgeon, for example. But it's important to know about because you may be counselling about it, but also these types, this topic area does get tested in the AKT and the MSRA exam. In terms of air travel, now this is an interesting subject area for antenatal counselling, so women who are pregnant. It's not known to be harmful, so if you're pregnant and you want to travel by air, it's not known to be harmful according to the evidence base. However, with long distance travel, there's an increased risk of VTE, for venous thromboembolisms. So you want to counsel on that based on obviously general VTE safety advice, so increase fluid intake, make sure you're staying mobile, stockings, for example, and you can refer to the NICE guidelines for VTE prevention, and there's a lot of information that covers that. But with regards to flying, there is actually some guidance from NICE about when not a woman who's pregnant should be flying. So their guidance is actually to refer to the specific airlines to which the patient's going to be flying on. And the reason for that is some airlines, for example, British Airways, have strict criteria for women who are pregnant. So if a woman is, and this is a generalization for most airlines, if a woman was between 29 to perhaps 37 weeks pregnant or above 29 weeks pregnant, and it's a non-twin pregnancy, most airlines wouldn't allow that woman to fly. Again, it varies from airline to airline. Some say 29, some say 37. Yeah, and the advice you need to be giving the lady or the woman is check with the airline with which you've booked. And then across the board, it seems that if a woman's got twins or multiple pregnancies above 32 weeks, most airlines would not allow that woman to fly. Now, you've got a slightly grey area, and the grey area is if the woman's between, let's say, 28 to about 32 weeks or 35 weeks pregnant. Again, it depends on the airline. Some airlines may ask a pregnant woman for a letter from the doctor or the midwife. And the reason for that letter would be when's the due date, so obviously they can work out how many weeks the woman is, but also they want confirmation from the doctor or the midwife that the pregnancy is at a low risk for complications. And I suppose the airline's doing it from a medico-legal perspective, because the last thing you need is a woman going into childbirth on an aeroplane and she runs into complications, and you don't have medical assistance or medically qualified person on that aeroplane. So the advice you want to give a patient who's in a clinical setting is obviously get in touch with the relevant airline for which they're flying. But if they need a letter again, as a doctor or potentially the midwife, you can do that letter based on the information on this slide, that their due date is such and such, and they are low risk if that's the case. Now, in terms of maternity benefits, again, this is a question which comes up more so in the AKT, less so the MSRA. And again, it can be asked in a clinical type setting. So all women are entitled to 1 year of maternity leave. So that's broken down to 26 weeks of ordinary maternity leave and 26 weeks of additional maternity leave, which essentially makes up a year. They're also entitled to free prescriptions and dental treatment during pregnancy, but also a year after birth. So it's important to signpost that if you're counselling a woman who's come in and recently become pregnant. Legally, a woman's required to stop working after 33 weeks. That can be an AKT question, by the way, unless the GP or the midwife informs the employer otherwise. And then don't forget, it is illegal for a woman to return to employment 2 weeks after childbirth, or 4 weeks if they're in a factory type setting. So that's very, very important to know. Now, there are maternity benefits in terms of maternity pay that they can get from their employers. The government guidelines change on a regular basis. So it's important to check the latest guidelines. And if you go into the NICE guidelines for antenatal care, there's a link for the Gov website, which talks a bit about maternity pay and when it becomes eligible. So usually the employer, for example, has to pay normal pay for between 4 to 6 weeks, and then it's maternity pay for I think it's a couple of months thereafter. But again, just check the latest government guidelines on that, because it can change. With regards to vaccinations, now this is a very, very common question which can come up in the AKT exam, sometimes tested in the MSRA as something you should be signposting if you're speaking to a woman in a clinical setting, and that is that the woman should be offered 2 vaccinations. One is the influenza vaccination for the flu season at the relevant time in the year, of course, but the other one is the whooping cough, which is the pertussis vaccination, and that's usually from 16 weeks onwards. Usually the midwife will be counselling her about this topic, but it's something you may want to signpost to get top marks if it's relevant for a woman who's attending to see you for antenatal counselling. And then, of course, scans. There are normally, in an uncomplicated pregnancy, 2 scans done so a dating scan between 10 to 13 weeks and a fetal anomaly scan between 18 to 20 weeks. Again, very common AKT question. So the dating scan will basically be checking for how old the fetus is, but also any major fetal abnormalities that may be detected. The fetal anomaly scan, which is a lot later on, is essentially looking for abnormalities in the fetus, which may be genetic or may have been as a result of perhaps changes in the uterus as the pregnancy's progressed. For example, if the woman's been consuming too much vitamin A. And those are the 2 key dates you need to remember: 10 to 13 weeks and 18 to 20 weeks. So I know we've covered a lot of information, and the reason for that is because this is a relatively large topic. Normally in these free webinars, we cover 3 key learning points, and it feels like we've probably covered at least 10. So just to recap, a couple of key areas you need to know with regards to antenatal lifestyle counselling for a woman: diet, certain foods to avoid. Diets, certain supplements to take, which is mainly folic acid and vitamin D, 400 micrograms and 10 micrograms. Exercise, that is okay, but certain exercises to avoid, and certain activities like scuba diving. Alcohol, smoking, drugs in general, they should all be, all of them should be avoided where possible. Sexual intercourse is fine, and it's safe throughout pregnancy. Toxoplasmosis is an increased risk with certain with certain things that may or may not be done. So you need to make the woman vigilant of these things, because that can increase the risk of developing a toxoplasmosis infection. Airline travel, the key message is to get in touch with the airline which they're flying. But generally speaking, most airlines around the age of around the gestation period of about 29 to 37 weeks would probably say no, not suitable for flying, and certainly the case if they're more than 32 weeks with twins or more than 1 pregnancy. So multiple pregnancies. And then don't forget, you may be asked for a letter by the airline or by the patient if the airline's asked for proof of their due date and that they're low risk of complications. Don't forget about maternity benefits. So maternity leave is 1 year free prescriptions for during pregnancy and 1 year after birth. The woman has to stop working after 33 weeks, and they cannot work for 2 weeks after they've given birth, or 4 weeks if they work in a factory. And then finally, don't forget the 2 vaccinations that must be given to pregnant women, or should be offered, sorry, for pregnant women. And that's the influenza and the whooping cough, the pertussis vaccination. And finally, the 2 routinely done scans for uncomplicated pregnancies, the dating scan between 10 to 13 weeks, and the fetal anomaly scan between 18 and 20 weeks. So this topic area is super, super large. There's so much to cover because I've just covered the lifestyle side of things. There's the actual midwife side of things, which is the blood tests, the triple test, so the screening test that they do for Down syndrome. There's a lot of other information which you should be going over as well, and perhaps we'll cover that in a different webinar. So let's see, there are a couple of questions. So Delapo, that's the triple quadruple test. We're focused more on the lifestyle side of things today. You're absolutely right. There are the blood tests which are done, for example, the full blood count, the sickle cell testing, and so on and so forth. The triple test, the quadruple test. Those will probably be covered in a different webinar because the topic area is so broad. There are 2 more questions which I'll come back to shortly. What we're going to do, we're just going to bounce out for a moment because we're just going to share 1 or 2 things with everybody. So if you just bear with me, I know there's 2 questions waiting in the Q&A in the Q&A box in Zoom. So let's see. Okay, guys. So quick show of hands. Who here is going to be sitting the AKT exam in the next 3 to 4 months? Just raise your hands if you're sitting the AKT exam in the next 3 to 4 months. So I can see 2 hands have gone up, 6 hands have gone up, 5. So just keep your hands raised if you're sitting the AKT exam, the MRC-GP AKT exam in the next 3 to 4 months. So 8, 9, I think 9 hands. Okay, 9 hands. So for those, that's fine. I'm going to lower everybody's hands. For those of you who are sitting the AKT exam, 2 key products to be aware of, very, very helpful. So we've got the free question bank, AKT free question bank. Please use that. It's free. Lots of useful features. But we have the AKT Gold Package. So the Gold Package essentially has got an extra additional 750 bonus video MCQ questions, 750 mini video lectures, 750 nice guideline podcasts, and also you get free flashcards posted out to your home address. It's priced at $149.99, but it's don't pass, don't pay. What that means is if you fail the exam, essentially you get your money back minus a small admin fee. So if you want to, if you feel like you don't want to take a lot of risk but get maximal revision material or preparation for the AKT exam, the Gold Package is the one to go for. So I highly recommend it. Very, very low risk. If you fail the exam, you'll get your money back essentially. And then don't forget, we've got the Akt Big Mock Exam on the 18th of April. We've got a discount on the website, 23% discount. So it's normally priced at £130, but at the moment it's $99.99. Full day mock. So we do a Zoom mock, 180 questions for 3 hours, approximately 3 hours, 10 minutes. 1 hour lunch break, and then me and Dr. Sandu go through all the nice guidelines relevant for the exam questions and the answers for 6 hours thereafter. Really, really useful because you'll learn so much in a 6 hour window after the actual mock, and you can see how you're doing and what your weak areas are, where you need to improve just before the exam. So you can actually boost your mark significantly by sitting for this mock, and it's very, very, very reasonably priced. Okay, guys, quick show of hands. Who here is going to be sitting the RCA, so submitting for the RCA exam in the next 2 to 3 months? Quick show of hands, next 2 to 3 months, if you're sitting or submitting for the RCA exam. So Sharayu, MK, Napoleon, Niraj, Mag. Okay, guys, for those of you who are sitting the RCA exam in the next 2 to 3 months, we've got an RCA Advanced Communication Skills course tomorrow. It includes live role plays, so you can obviously practice. It's a 5-hour day essentially. So we go through 5 key high yield areas for communication skills. Important ones like result stations, counseling, we cover angry patient, telephone consultations, ethics, acute illnesses, chronic disease management, 2-week waits, So all the important things that you need to know to get the top marks for communication skills for the RCA exam when the Royal College examiners are assessing. So if you feel like actually you'd want to know what the RCA examiners are looking for, how you can boost your interpersonal skill marks for the RCA exam, this is the course to come to. Again, it's very, very reasonably priced for a full day course, $49.99. You will learn so much, and it'll probably be very, very good value for money when you look back after you've done it. So all you need to do is, for all the products, click on the date, add to cart, the button's there on the right, and then check out. And then finally, there is actually, we've got some RCA videos as well. So if you feel like you need some extra preparation, Dr. Sandu is going to include the links for you guys shortly. But there are gold standard videos that we've recorded that you can watch to see how you can score the top marks with in-video breakdown. There's different packages depending on your budget, but you've got a free package if you want to check out what the videos are like. Again, they're very, very useful. And then finally, quick show of hands, who's sitting the MSRA exam in the next 2 to 3 months? Just raise your hands. I know there was a January sitting, so I know there's a January sitting, so there's one of you. MSRA exam, if you're sitting it in the next 2 to 3 months, just raise your hands. So there's a handful of you. Again, we've got an MSRA Gold Package. It contains bonus questions, 750 videos, podcasts, and again, we post out free. We post out flashcards for the MSRA exam. Again, it's don't pass, don't pay. So if you fail the MSRA exam, essentially we refund the money. So that's the key products to be aware of. The only other thing I'm going to add is going to bounce back into the presentation because I know there were 2 questions. Let's have a look. Okay, so there were 2 questions. What about raw fish with regards to listeria? So that's a good question. Probably you're going to be more concerned about a salmonella type infection with regards to listeria as opposed to cheeses. Sashimi, I'm not entirely sure about that. I'm not sure if it's a raw fish, so you may need to double check sashimi where it falls into the NICE guidelines. The government's got some guidelines as well. What I do know from the NICE guidelines is certain fishes are essentially high risk for salmonella, and those are raw shellfish or undercooked or underprepared meats, which would include fish, of course. And then with regards to twins, do you increase the supplementation? The short answer is no. So even in a twin pregnancy, it will still be 400 micrograms of folic acid and 10 micrograms of vitamin D. The last thing to add, guys, before Dr. Sandu pops up on the screen to cover the second part of this teaching session, is I'm just going to include a link for you guys. So Vikas, I'm just going to let you screen share whilst I do this. If you want to perhaps just load your PowerPoint.
If you can let me do the screen share, and then I will.
There's one more thing, guys. We do these free. We do these webinars for free. It's like a Saturday evening, and we hope you don't mind if you could perhaps just leave us a nice Google review. I'm going to put the link into the chat box. Once you click on it, you'll end up on the Google page for iMedics. On the right-hand side, it'll mention the reviews. If you click on it, you can leave us a review. Literally takes 20 seconds to do. Hopefully a nice review if you don't mind, because we do take our time out to do this free teaching for you guys. We would love for you obviously to pass the AKT with the RCA or the MSRA exam, and that's the reason why we've got free question banks on our website. So if you want to show us your appreciation, that's the way to do it. We really, really appreciate it. And I'll include the link in the Zoom box in the next 20 seconds.
Okay, perfect. So thank you very much, Dr. Mo. So that was an interesting first part of your obstetric revision program. So lots of take-home learning points about some of the things that you should be counselling newly pregnant women who attend your clinic. So very relevant to RCA, and of course the kind of the things to avoid is a common question for the AKT exam. So it's important that you kind of registered some of that information. You can watch it back on YouTube if you've missed anything, but some useful learning points there. So we're going to move on to the second stage of your revision webinar, and we're going to focus specifically on nausea and vomiting in pregnancy using evidence from the current NICE CKS guidelines. As we do with all of my presentations, we've got a few objectives that we need to cover. That will include how we define nausea and vomiting in pregnancy, and what are the key causes. What do we need to do when it comes to diagnosis? How should we be examining and assessing these patients, and management? And management's very important because there's obviously lifestyle measures here, but there is also medications, and people often get worried about what kind of medications they should be prescribing someone who's pregnant. So we'll obviously cover that, and hopefully you'll have some confidence at managing this case in your clinics as well as your RCA and AKT exams. So what's the definition? Well, basically nausea and vomiting is in pregnancy is basically defined as a woman who feels the urge to have nausea or persistently vomits, and there's no other cause found for those symptoms. So that's what the Royal College of Obstetrics and Gynecology defines it as, and that's what NICE has used for its definition as well. So essentially it's vomiting that occurs when we can't find any other cause for it. It's a relatively common finding, as of course many of you will know from your clinics. So what can be the causes? Now, there's a few things to be mindful of. So you would have heard of the HCG hormone, which is the human chorionic gonadotrophin. And what we seem to know at the moment is there is a relationship between that and nausea and vomiting. And the theory basically is that the higher the levels of HCG, the more likely you are to have nausea and vomiting. And they found that in some studies, that there's higher rates of HCG in twin pregnancies and in molar pregnancies, and in those females they tend to have raised HCG levels. So that's where that theory comes from. The second cause is estrogen. So increased estrogen levels are thought to cause an increased risk of developing nausea and vomiting in pregnancy. NICE mentions evolutionary adaptation. Now, this is a kind of a way in which we have kind of changed over time. And it's basically that the nausea and vomiting is actually an internal mechanism that's designed to stop women from consuming foods that are going to be harmful for them. So Dr. Mo touched on things like salmonella, seafood and various other things. And this is only a theory, by the way. It's not an exact kind of science behind that. But they do suggest that having that mechanism in place will mean that the woman is unlikely to kind of go near food that will be harmful for her. The fourth thing is gastric dysfunction. So when a woman is pregnant, as it makes sense, you can see in this picture, this lady's early pregnancy. So she's not, her kind of tummy has not got significantly big at this stage, but it is starting to get big. And what happens is the pregnancy gets big, it puts pressure on the food pipe, the esophagus, the tummy, so the gastric part, and also your small bowel. And so these areas become less mobile. You get smooth muscle relaxation because of the increased progesterone, and that causes decreased gastric emptying, and therefore you're prone to developing the side effect of not feeling like you're going to be sick and actually then vomiting afterwards. Then you've got vestibular and the olfactory system. So basically, one of the other theories that they say women are more likely to get nausea and vomiting in pregnancy is because your pregnancy seems to kind of lower that threshold of the vestibular system. And so people get this kind of nausea feeling, an urge to vomit. And again, it's thought to be the fact that you've got this increased estrogen. So going back to the second point we mentioned up here, where we spoke about estrogen levels, increased estrogen levels lead to an increased risk of nausea and vomiting. In the same way, those increased estrogen levels seem to activate that vestibular system, leading to vestibular-mediated vomiting in pregnancy for some women. Then there's psychological influences, and NICE mentions this interesting point here, which is that sometimes, well, some people have claimed that nausea and vomiting is actually an abnormal stress response to negative feelings about pregnancy, but there's very little evidence to support this theory. And actually, some people, the other alternative to this is that actually it's kind of feeling low, feeling anxious, feeling agitated. So psychological symptoms actually kind of may occur because of the nausea and vomiting in pregnancy rather than the other way round. So a few key causes to remember, but remember, in most cases we don't find a cause. Most of it is spontaneous, as we'll talk about in the slides that are coming up. So in terms of diagnosis, what things do we need to know about? Well, just remember that obviously that we diagnose nausea and vomiting in pregnancy based on the symptoms that the woman will obviously tell us, whether that's on the phone during the pandemic, or of course, before the pandemic, when they'd come into our clinics and we'd see them and they'd tell us about, the symptoms that they had. And women will often tell us that they're either going to feel like they're going to be sick or they actually are vomiting. And also they can have issues like, for example, they just don't like the smell of food and they try and avoid food because each time they look at it or they smell it, they feel like they're going to be sick. The nausea and vomiting tends to begin, it's important, I've highlighted in red here some key points. So nausea and vomiting in pregnancy will usually begin in between the 4th and 7th week. And it will kind of hit its peak between the 9th and the 16th weeks. And it tends to resolve by the 20th week of pregnancy. So generally you can see that it's quite common early on, kind of peaks for a few weeks. And by the time you get to week 20, most women will basically have had their symptoms resolved. The NICE guidance does mention an interesting point, which is that if you get nausea and vomiting that starts at 11 weeks of gestation or later, that's normally not a kind of normal pregnancy response. And so we have to do some further tests to look for other causes, like, for example, thyroid hormone, which might be abnormal, and therefore that might be contributing. And generally, you tend not to do blood tests unnecessarily unless you suspect hyperemesis gravidarum, which we will talk about in the third box. Some women kind of have severe symptoms, and that leads me on to the hyperemesis gravidarum point, which is basically a persistent vomit that occurs, which is not caused by anything else. And it's key things to bear in mind here. The woman will often have weight loss. NICE defines it as at least 5% of their pre-pregnancy body weight. They'll have evidence of dehydration. So remember, when you do your clinical examination, your reduced skin turgor, moist mucous membranes, they're very dry around the mouth when you're looking at them, and ketones in the urine. So if you're suspecting hyperemesis gravidarum, and we do, I think I've seen, so having been an FY1 doctor on the gynae emergency unit, we used to see hyperemesis gravidarum quite a lot. As a GP, I've seen quite a few cases. Many don't need admission, but some do. And of course, the way we work that out is we do the clinical examination, looking for features of dehydration. And most importantly, we get them to bring that urine sample in. It's a good practice that if you're preparing for the RCA, would be while you're on the phone, you would say, Mrs. Smith, I'd like to see you. Are you okay to come in at 2 o'clock? Would it be okay if it's all right with you, if you can bring a urine sample with you, or maybe come to the surgery a bit early and our receptionist will give you a white top bottle. And therefore, when she comes into your room and you examine her, you can obviously check, you can do the urine dipstick and have a look for the ketones. Because remember, if there's ketones in there, and we then know that she's very severely dehydrated. And what happens on the gynae assessment unit is normally they're not admitted for long. It's normally just under 1 day. And they'll normally have IV fluids, often over 6 to 8 hours. And normally they have a bit of potassium in the bag. And then they're given some antiemetics and they're sent home once they're able to tolerate fluids. And normally most women do get better. But you do see some cases. It's important that you're mindful of the women who've got hyperemesis gravidarum. Nothing stays in, everything comes out. And eventually they end up pretty dehydrated, which puts them at risk as well as the baby. So examination and assessment. So let's set the scene. You've got the patient, you've brought the lady into your clinic, and what things can you do and what should you be doing according to the NICE guidance? It's very important that we monitor weight. So you may already have a weight on the system. So most of us use EMIS, some of you may use System 1 and other GP medical record systems, but essentially there may already be a weight on there, especially if the midwife has already seen the patient. Otherwise, it's important that we get the weights, because if they do come back to us, and we've got an objective measure, we can look back to see if that weight's fallen, if they come back in. Examine is the second thing. So we look for signs of dehydration. So we touched on them before, the dry mucous membranes, the impaired skin turgor, a raised pulse, which is also a sign of dehydration. And of course, checking that blood pressure when they're moving from sit to stand. And often what you'll find is that there's a significant postural drop. And often women complain of feeling very dizzy and very lightheaded and very weak and lethargic. We look at women, of course, in terms of the examinations, you have to look at the edge of the bed. Remember, when you go back to med school, they always say, look, feel and move. And it's no different here. You're looking for signs of muscle wastage. And of course, the test. So test for urine in the ketones, very, very crucial. One of the most important things here, test the urine, because, if you find that there's ketones in there, that's a criteria for admission. Then there's obviously a couple of things. So 2 things to consider: assessing for signs of low potassium and hyperthyroidism. So remember, you're looking for things like a tremor. You can get them to stretch their hands out, and you can maybe put a paper on top. And if they start to shake excessively, that's a very worrying sign. They might be sweaty, there might be a goiter, there might be a tachycardia. So these are things to be mindful of. And then finally, we can also consider doing an ultrasound scan in women who are stable, and we can get them an appointment at the obstetric clinic. And that's when you're looking, for example, for if you're suspecting a twin pregnancy or a molar pregnancy, because remember, those type of pregnancies tend to be much higher risk for persistent nausea and vomiting. Management then. So now what are the key things to take home from here? So these are some advice-based measures that we give to pregnant women who present with persistent nausea and vomiting. The first thing is reassurance. So often most cases will resolve by week 16 up to week 20. We can tell them about food, avoiding certain things. So for example, any food which might look like it's going to make them feel sick, or it might smell in a certain way that will trigger their nausea. And that classic examples are spicy and fatty foods. She can try things like eating plain biscuits or crackers in the morning before getting up, or like sort of small frequent meals which are low in carbohydrate and fat but high in protein. And the theory behind that, remember that the protein is very important because you need that for muscle build up and general strength. And obviously, like high fat and high carbohydrate foods can be quite sluggish, and they can make you feel quite sick, and so it's better to avoid them if you're feeling like you're going to be sick in the first place. Cold meals tend to be better tolerated if that nausea is triggered by the smell of food. And then obviously drinking little and often is a very important concept. This is something that we tell children when they come in. Often parents say, okay, should I just give the whole bottle? Well, the trick is always you have little and often, because if you give the full bottle, they'll vomit it back. And it's the same here. What you don't want to do is say to the woman, just drink, a gallon, liters and liters of water, and you'll be absolutely fine, because the likelihood is she'll vomit all that back up. So you say to her, look, have regular small sips throughout the day to keep yourself topped up. And then a couple of things to be mindful of. Ginger in the diet is found to be quite useful when it comes to preventing nausea and vomiting in pregnancy. And acupressure is interesting. So you can get these little pressure bands from the pharmacist and from some supermarkets and so forth. And they put some pressure at the wrist, and they're actually found to reduce the feelings of nausea and vomiting in some women. So it's a very useful self-help measure that we can suggest. Then what medication? So this is always a tricky bit. So when it comes to prescribing medication for women who've got nausea and vomiting, we often seem kind of a bit apprehensive and a bit nervous about what can we prescribe, what's safe to prescribe. And so NICE gives us some advice on what we can do here. A couple of things then. So the first options you've got are your antihistamines. The common ones are things like cyclizine or promethazine. So when I was at the gynae assessment unit, I don't know if some of you have worked in Leicester, but I was at the Leicester Royal Infirmary as a junior doctor, and they often gave promethazine on the ward, but either of these two can be given. And then your other options, you've got oral prochlorperazine, which is often a useful alternative medication as well. And we should be reassessing the woman after 24 hours. Now, how do we do that? Well, before the pandemic, we just book them in. You do it yourself. You don't have to rely on a receptionist because the patients may not get an appointment. So you'd say, Mrs. Smith, I'm going to book you in tomorrow at 4 o'clock, and we'll see how you're getting on. Of course, at the moment, we're doing telephone consultation. So again, it makes sense. You manage the patient safely. So you book them in for the next day at 3 o'clock or whenever it is. And you say, listen, we'll have a call tomorrow. We'll see how you're getting on with the medication, how you're doing with your fluid intake, whether you're still able to keep food and fluids down, whether you're passing urine, very important markers to look for. If the response to treatment is good, then we carry on with the treatment with the antiemetic that we've gone for, and then we can have a review of her in 1 more week after this, just to make sure she's still going along the right path. And then you can kind of, safety net, and she can get in touch with us if symptoms don't settle. If the response to treatment is not very good, or she's dehydrated, but she's not dehydrated and there's no ketones in the urine, we can try another antiemetic, which we didn't try before. For example, if you tried cyclizine, you can switch to promethazine. But there are second-line options as well that can be given according to NICE, and they are oral metoclopramide or oral ondansetron. And again, these should only be given for up to 5 days. And remember, you're going to be reassessing after 24 hours, and then you should be following up a week after. So no more than 5 days, but metoclopramide and ondansetron orally are your other two alternatives. Safety netting. So remember, when you're doing your RCA or CSA exam, you've got to obviously safety net. So we're going to tell them to come back in 24 hours. But if things start to get worse, and these are some of the things that we should be looking out for. So very dark urine, or not passing urine for more than 8 hours, that's a red flag. Now, dark urine will only happen if she's not had enough fluid in her diet, and that's because she's vomiting, and that would suggest that she's heading towards severe dehydration. Abdominal pains or fevers are worrying signs. Severe weakness or feeling like you're going to faint all the time. Vomiting blood or repeated unstoppable vomiting. Now, some women do say everything I touch just comes out and it's projectile and it's just not staying in no matter what I do. Normally when women say that, that triggers the red flag in my brain, and it makes me think that, okay, we've definitely got to check the ketones. We've got to examine this lady, and then we've got to make a decision as to whether we can safely manage her at home or whether she needs to go to the gynae assessment unit. The couple of other red flags are inability to keep down food or fluid for 24 hours, because again, that means that you're heading for severe dehydration. And then there are associated symptoms like severe headaches, problems with the vision, sudden swelling of the face, hands, or feet, which are kind of early symptoms of preeclampsia, and therefore they need to be seen on the same day for further assessment. So they were a couple of take-home messages, so we will open up the floor for questions. If you haven't done so already, I'm sure some of you, many of you will be following us on our social media channels. We've got lots of good revision material on there. Instagram, inspire_medics. The Facebook AKT, RCA and MSRA revision group is very useful. We're on YouTube at the moment, so if you are joining and you've got any questions, you can obviously type it in, but do follow the iMedics YouTube channel, which has lots of revision videos, and the Twitter page, inspire_medics as well, for revision and updates on our up and coming courses. So we'll open up the floor to any questions, and I will.
So there was a question on cyclizine, which I've answered, but you may want to, I don't think you need to expand on it. So the question was from Yvonne, how long can they have cyclizine for? And from my understanding, it should be avoided in the third trimester. So sedating antihistamines in the latter part of the third trimester may cause adverse effects in neonates, such as irritability, paradoxical excitability, and tremor. So the first, essentially, nausea and vomiting is usually common in the first trimester. So essentially, you want to avoid it by the time they get to the third trimester.
Yeah, absolutely. So I think the take-home message there was in the guidance, wasn't it? Which is after 11 weeks, if it just suddenly starts to appear, you need to be looking at other causes that might be causing the patient's symptoms. So most patients would have got better by then. Otherwise, you'd need to get them assessed in secondary care. Any other questions that have cropped up?
There's a couple of questions that have come up in the chat box. Just whilst Dr. Sandu is reviewing those in the Q&A box, just going to show you the iMedics forum. So the iMedics forum is where you can have discussions depending on which exam you're sitting. It's a relatively new feature, so actually it hasn't been filled out that much. But essentially you can go to, for example, the GP exams discussion board and discuss things. The way to access it, if you go to the mega menu at the top or the burger bar on your phones, if you click on forum, which will be there on the right-hand side at the bottom part of the burger bar menu, and it will lead you to this page when you click on it. And then we've also got a blog section. So if you click on in the mega menu or the burger bar menu on your mobile phone, if you click on the blog section, there's different areas for the blog. So you'll have patient information leaflets, doctor information leaflets, and you'll also have so you'll have patient information leaflets, iMedics blog, and also doctor's blog. If you click on the doctor's blog, you've actually got relevant blog articles or articles relevant for the exams you're sitting. So we've got AKT articles, MRCGP, RCA articles, and also the MSRA articles. Range of different articles on different topic areas: endometriosis, oral hygiene, stages of medical training. And so let me go into the AKT one. So if I go to MRCGP exams, if I click on that, then it'll bring up the relevant articles for that particular exam that you're sitting. So breaking bad news, safety netting, constructing the perfect job, procrastination. But then if I go later on, so if I scroll across the different blog articles, you'll see that there are some super focused ones as well. So hopefully they come up. Menopause and HRT, measuring vitals, GCS, developmental milestones, smoking cessation, shoulder examination. So there are relevant ones for the exam you're sitting. So certainly do check that out. If you're unsure on how to leave a Google review, we've included a link in the chat box. It doesn't take long, guys. So if you type in iMedics, or the link that we've provided, you'll end up on this page. On the right-hand side, there is a Google Reviews link. If you click on that, you'll get a pop-up, and then from there, you can leave a review. So if you're unsure how to do that, that's the way to do it. So I'm going to hand back over to Dr. Sandhu, because there are, I think, 2 questions in the Q&A icon box.
Perfect. Thank you very much, Dr. Mo. So Jules asked an interesting question, which where does doxylamine fall? Now that's interesting, because many of you might not, well, most of us won't know what that is. It's basically kind of a first generation antihistamine. It's not something which has been mentioned in the current NICE guidance, so it's not something which we would give. I don't know if anyone else who's joining us on the webinar is familiar with that medication. And Jules, perhaps you can give us a quick chat comment there about where you kind of, if you do use it and where you practice as well, because it'd be interesting. Innocent's question, what are the indications for the management of nausea and vomiting? So I'm not sure where that, I'm assuming that's, what are the indications for nausea and vomiting? So I'm not sure that question makes sense, actually. So I'm assuming it's what are the indications for the management of nausea and vomiting? But I think that will be linked to a question which I think Rahat has asked anyway. What level of ketone urea requires admission? What if the lady looks hydrated, but the ketone urea is 3+? It's a very good question. So tying those 2 questions together, it's very important that, you know, we assess. So we take a good history, we find out what the fluid intake is, how often she's vomiting, whether she's managed to eat anything at all, whether she's passed urine, whether she's got any symptoms like headaches, vision problems, lethargic, feeling faint. Then, of course, we examine, and we remember mentioned this thing of look. So you look for features of muscle wasting, look for features of dehydration, look for features of postural hypertension and tachycardia. And of course, you dip the urine. Now, if there's 3+ ketones, that would be an admission, because that would suggest that she is still significantly dehydrated. And it might be that either you've missed it on the examination, but the ketones are huge. And that's a significant thing. That suggests that she's severely dehydrated, and really managing her in the community is not going to be safe. She's going to need some IV fluids. Remember, they don't get admitted for too long. So some of you will have done gynecology or obstetric posts as part of your foundation training or your GP training. So you'll know that most women are not admitted for too long, normally less than 24 hours. And they normally need a couple of bags of fluid, bit of potassium in there as well, and some IV antiemetics. And normally they get better reasonably quickly, and they can be switched back to oral medication, and obviously managed in the community. So urine is very, very important. I think I've admitted a couple of women in the last 12 months. And normally, again, I get them to, you can normally tell when you take the history that something's not going to be quite right. And I think Dr. Mo's also pasted in a couple of bits there as well. Body weight's obviously very important. So have a look to see if the midwife has already done one. If not, it's important that we should do one, or you can ask the lady to do one in the reception and get the receptionist to record it on the system so that you've got it on your record as well. So a good couple of questions. If there's any other questions, guys, do let us know. We have put in the links for our social media channels as well, so do follow on there. Here we go. Jules has got a thing. So used a lot. So that was the question. Doxylamine used a lot in some parts of Europe because of the vitamin B6 combined with it, which is interesting. Just wondering if it's safe, as it's not mentioned in the NICE guidelines, like you just pointed out. Yeah, very good point, Jules. And it's interesting to see what kind of practice is being doing, what kind of practice occurs in other parts of the world. Certainly not mentioned in the NICE guidance in the UK. And so obviously stay away from it in the UK, but that's not to say that the European guidelines in other parts of Europe will not use that as a drug. But certainly NICE haven't mentioned it in their guidance, so I'd probably stay away from it. It's probably one that, well, I don't think dare I say to the audience here, if you put your hands up if you've actually used or heard of that drug before, which would be interesting, because I know some of you are joining us from other parts of the world, but most of you are in the UK. And certainly from some of the aid work that I've done in the past, there are various other drugs that other parts of the world use, which we don't use in the UK for different reasons. Good, okie dokie, perfect. So if there's any other questions, guys, do let us know. Otherwise, we'll look to wrap up in the next 30 seconds or so. Doesn't look like there's any more questions that have cropped up. Obviously, thank you very much for joining us on a Saturday evening. It's been a good turnout as well. I know we had an issue with our website a couple of weeks ago. And so the last webinar, many of you probably would have missed it because you probably didn't even know it was there. But we have sorted all those issues out now. So it's great to see a fantastic turnout on here and on the iMedics YouTube channel. Do have a look at the social media channels. We've got some good revision material coming. Do let us know if there's any topics that you want us to cover, because we tend to be guided by some of the things that you guys are struggling with. Of course, there will be another webinar coming up in the next few weeks as well. Hopefully, we'll see some of you on the AKT mock and at the RCA Advanced Communication Skills course. So closing comments from me then. So thank you very much for joining. Hope you're all keeping safe. Hope your families are keeping safe in this difficult time. Hopefully we will all be coming out of it. Most of us have had our first vaccine, second one's coming up now as well for some of us. So, so final words to you then, Dr. Mo, before we close for today.
Absolutely. So last couple of things, guys. Don't forget that the AKT question bank, the PLAB question bank, and the MSRA question banks are all free. So do use them, do mention them to colleagues and friends. For tomorrow's, this is from W2Fail. Can you give us a quick idea for tomorrow's RCA event? Yeah. So it starts at 10 o'clock. It's an RCA Advanced Communication Skills course, and we cover 10 high-yield communication skills areas. We do 5 live demos, live cases on the day, so you can do 5 live mocks with feedback. So me and Dr. Sandor will be giving feedback, and we'll be going through all the common scenarios that you may be expected to submit for the RCA exam. And there's a 1-hour lunch break, and I'll just bring up the day schedule for you. So it looks something like this. So 10 o'clock starts, first high yield communication skills areas covered between 10:15 and 11:15. The next one starts at 11:30, 1-hour lunch break, and then we do 3 back-to-back sessions with a break in between in the afternoon. Loads of learning, a lot of learning will occur. There's a bit more description at the top in terms of the types of scenarios we cover. So sexual history, ethics counseling, acute admission counseling, examination results, telephone consultations, chronic disease management, 2-week waits. How do you actually manage those cases with regards to communication skills to score the top marks? And that's the real focus of this course. It's only $49.99, so it's extremely good value for money compared to some of the other courses in the market. So I hope that answers that question, Dr. Tufail. The last couple of things to add is we'll send you out the link for the next free teaching session in the next couple of days. So the next free teaching webinar for the AKT, RCA, and MSRA will be in a couple of weeks' time. Do hopefully check out the parts of the websites that we showed you, so the blog, the forum section, and also the products that we mentioned. If you haven't left us a Google review already or historically in the past, please do leave us one if you found this useful or if you found the question banks useful. And then if you do want to get in touch, you can always drop us an email or the contact us page on our website, so that's not a problem. So from myself and from Dr. Sandhu, thank you for joining us. Please do stay safe. We do wish that you all pass your exams on time, because I know a lot of you have got plans in terms of, I want to move on to this stage of my career, or maybe something to do with family.
So, yeah. Mo, just a very quick one. So I've just logged into YouTube. There was a question on there. So from Omar Mohammed, I don't know if he's in the Zoom, but it's basically, hi all, I've registered for the AKT mock exam on the 18th of April. Are the questions live on screen or email before? So Omar, if you're listening on Zoom, or if you're, I think you're going to be watching us on YouTube, but basically it's a live mock exam. So you will do the exam in the time conditions, for, in the morning, and it will be from home. So it will be live. The questions will be going through as they would in the real exam. And then in the afternoon, there's about 5.5 to 6 hours of good teaching with myself and Dr. Mo, with at least 200 plus points that are discussed from the current NICE guidance. So it's quite a detailed mock. There's been some very good reviews on Google If you just have a look at the tabs, you can look for the AKT mock from the last set of students who came through. And it's quite high yields. It's a full-on day, but you do get lots of high yield information. And most of our students feel really super prepared. So if you are listening, I think Omar's probably on YouTube because I can't see him in here. And the question was on YouTube, and I just saw that in the chat. So hopefully, Omar, if you're still there and you've had that, that answers your question for you.
Okay, guys, I think that's everything. Do take care. Do stay safe. We'll see you very, very soon, and all the best. So we're just going to end this now, but there'll be a recording available on YouTube if you want to watch